Good afternoon, students. Welcome to R.A.T.S in Pathology, Racing Against Time for Students in Pathology. I had just started the topic on liver, and paradoxically, I'll be going to the introduction to cirrhosis and portal hypertension now. I would like you people to deftly follow this because this shall pave way for many other topics to follow. The class for today will be dealt under the following headings as shown on the chart. There are two basic things. One is cirrhosis in general and two, portal hypertension. Both of these topics are of enormous importance. This is a gross and a microscopic picture of the normal liver. The normal liver is shown for us to appreciate the color, the contour, and the lobations. On the right, I've got the microscopic picture. So this is a hepatic lobule with the central vein, the portal triad, and the radiating cords of hepatocytes. And for labeling, the zone around the portal triad is called 1, around the central vein is called 3, and the mid zone is 2. This again is a very basic concept which I would like you people to appreciate repeatedly. The central vein, radiating cords of the hepatocytes, the sinusoidal spaces in between, and the portal triad at the alternate angles. And this is a hexagonal outline of the liver lobule. And here again is a picture of the hepatic parenchyma that is being separated by the sinusoidal spaces. Sinusoid is nothing but a very small blood vessel which is having a fenestrated endothelium. And here again we are seeing the biliary canaliculi. Let us have all this in mind. I do not want you to memorize it, but a basic concept which will make our understanding easier. Again, a higher magnification showing the cords of hepatocytes, the space of Dicey, the fenestrated endothelium, and the sinusoidal space. The blood flows towards the central vein and it is drained into the inferior vena cava. Fatty liver is a topic that we had dealt with earlier, both under the gross as well as under cirrhosis. And these are the various etiological causes for fatty liver. Alcoholism, starvation, obesity, diabetes, steroids, LCAT, carbon tetrachloride poisoning, Ray's syndrome, orotic acid, to mention a few. The strange thing is, any of this can be asked as an MCQ as exemption. All are causes for fatty liver except, and we should have a fair idea about it. Also, you may be having a specimen of this in your viva. They can ask you the various causes. Please appreciate the yellowish color on the cut surface, the shiny capsule that is stretched. All these have been covered, and I would like you people to go back to those classes. This is indeed of paramount importance, which has been omitted in the previous class. This is a diagrammatic depiction of the pathogenesis of the cirrhosis and alcoholic liver disease. A normal liver, you find that whenever there is a continuous exposure to alcohol, it goes in for a steatosis or a fatty change, and all the changes along with. The liver will be enlarged and it weighs about 4 to 6 kg, and you find that the hepatocytes have a fat cell-like appearance. And when there is going to be a continuation of the alcoholism, it can go into the second stage, namely hepatitis, in which these are the four things, namely destruction of the hepatocytes, inflammation, and there can be a fibrosis leading on. There will also be what is called as a Mallory body, which are inclusions seen within the cytoplasm. This can be seen in a number of conditions. Until now, probably it is a reversible one, and if there is any abstinence, the patient can have his normal liver back. But on continuation, it goes in for a permanent, irreversible damage leading in cirrhosis. So this particular schematic diagram is of importance to you people, which I want you to draw in the examination. This again is a line diagram of the normal liver and the cirrhosis. This has been shown earlier and shall be shown later also. Please appreciate the multinodularity, producing a hobnail pattern, and that is there throughout the cut surface also. The entire liver is involved in cirrhosis. I would like you people to draw these diagrams and explain. Cirrhosis. It comes from the Greek word kyros, which means tawny, firm, almost hard, and it is a generic term for the hepatic disease of varying etiology, just like anemia. Anemia by itself is not a disease, but it is a manifestation of many a disease. Similarly, cirrhosis. You can get cirrhosis in alcoholic liver disease or in Wilson's disease or in hemochromatosis and so on and so forth. And the basic thing that we will have to remember about cirrhosis will be these three things. 1. Effacement of architecture. 2. Fibrosis. And 3. Regeneration of the parenchymal nodules. Effacement of architecture, fibrosis, and parenchymal nodules. Architecture itself is a relationship of one part of the tissue to another. And this I have retrieved from the net, and this is the source which I would like to acknowledge, and what I call a stupid mnemonic, very important to us. What are all the causes for cirrhosis? Remember the word hepatic and you have the answer. H for hemochromatosis, primary hepatitis. E for enzyme deficiency such as alpha-1 antitrypsin. P for post-hepatic infection and drugs. A for alcohol. T for tyrosinosis. I for Indian childhood cirrhosis. And C for copper, that is Wilson's disease or cancer, hepatocellular carcinoma or cholestasis, biliary cirrhosis. Please do by heart this mnemonic. It is of some use to us. It will help us recollect faster. And this is the nodularity that we had seen earlier, the hobnail pattern involving the entire stretch of it. And this is the classical effacement of architecture. I do not see the central vein or the portal triads, and that relationship is lost. And there is a proliferation that leads to bulging of the hepatic lobules. And this is the fibrous tissue, F for the fibrous tissue. Cirrhosis itself can be macronodular more than 3 millimeters, micro less than 3, and mixed both sizes. Another topic, in fact, this would have been more important. In the examination, sometimes we are asked for the autopsy changes in or the clinical manifestations of cirrhosis. Also, portal hypertension is a very important clinical case for us. In the examination, they may ask you in pathology itself, what are the causes, mechanism, then the manifestations of portal hypertension. Let us see what we are having with us. Causes for the portal hypertension, they are mentioned here. They can be extrahepatic, which is a portal vein thrombosis. Intrahepatic, which can be pre-sinusoidal, sarcoidosis, schistosomiasis, a parasite which can lead to an obstruction and then there can be an increased pressure. Suprahepatic, the pre-sinusoidal cirrhosis. Cirrhosis is the most common cause of this. Budd-Chiari syndrome. Hyperdynamic cases such as right heart failure, arteriovenous fistula. Please do remember these, the various causes for portal hypertension. This is again diagrammatically represented. Please see this. There can be an obstruction to the flow in the pre-sinusoidal space. That can be again cirrhosis, schistosomiasis, or sarcoidosis. And whenever there is an obstruction to the flow into the inferior vena cava, as in Budd-Chiari syndrome or thrombosis of the hepatic vein. Sometimes there can be a veno-occlusive disease, as in the Bush tea drinkers. Also, you find that prehepatic, before the veins reach the liver, there can be a thrombosis, etc. That can lead to a portal hypertension. Various causes are there. I would like you people to kindly go through the list. One of the classical things that used to be asked in clinical medicine is, what are the sites of portosystemic anastomosis? And these are the various sites. The lower esophagus, rectum and anal canal, umbilicus, bare area of the liver, retroperitoneum, and PDA or PDV, patent ductus venosus. And this is again the list. What is the portal component, what is the systemic component, and where the anastomosis occurs. Lower esophagus, you find that these are the various components, and bare area of the liver, for example, portal venous branches, and then inferior phrenic and right internal thoracic vein. I would like you to kindly go through this, not for my sake, but for being a good student in medicine. After all, as is your pathology, so is your medicine. Please go through this particular list and study it. What are the classical signs of portal hypertension? There is something called as hepatic encephalopathy, which might result in lethargy and drowsiness, slurred speech, disorientation, hysterexis, or a flapping tremor as is diagrammatically shown. Fetor hepaticus with a musty odor and deep respiration. These are some of the causes. There are many more in medicine, but then this is the clinical manifestation of portal hypertension. And you find that there are the distension of the blood vessels all over, producing a head of Medusa or a palm tree appearance. Also, you find that there is a collection of fluid in the abdominal cavity described as ascites. Normally, about 500 ml of fluid is required for it to be clinically diagnosed. And this is the feature of ascites. This will be the classical case that can be given to you people in the examination. And what is the pathogenesis of this ascites? This, of course, is pathology. This will come under the topic on edema also. There can be increased hepatic lymph formation, or there can be a renal retention of sodium and water. So you find that there is an overfilling theory as well as an underfilling theory. In overfilling theory, there is a sodium retention leading to increased fluid volume. And in underfilling theory, there is a reduced blood volume. Both of this can result in ascites. And what can be the various other factors that we should appreciate? One is an increased pressure. The fluid, it should be at least 500 ml. 50 to 100 ml can be diagnosed by means of a puddle sign. The fluid that we usually have in ascites is a serous fluid. In other words, everything is low in it. there is a low protein, low color, and low cellularity. The protein is less than 3 grams. The color is pale straw yellow and it is of scant cellularity. This is the classical one, which is again the feature of a transudate. The portal hypertension, this particular diagram retrieved from illustrated pathology, is of paramount importance. There can be a splenic congestion or there can be a hypersplenism which can lead to an ascites. Also, you find that there can be an ascites which can be aggravated by means of hypoproteinemia or hepatic failure. There can be portosystemic shunting, in which esophageal varices, which is again of great importance, it can be life-threatening, leading to a hemorrhage. And there can be bypassing of the liver. Therefore, the metabolic activities are not there. There is a toxic effect which can lead on to hepatic encephalopathy. And these are the features in ascites. What we are seeing is a caput medusae, as though you are looking at a palm tree from the top. This is a superb diagram, again retrieved from the net, which shows the effects of portal hypertension. What are the complications of portal hypertension? One is esophageal varices. There can be hematemesis. There can be a melena. Splenomegaly definitely can be there. Caput medusae, ascites. Hemorrhoids is there, but it is not as harmful as hematemesis. And the patient can go in for a liver failure and a coma. Scleral icterus, jaundice will be there. Peter hepaticus, and it is something like a freshly opened corpse or a body. Spider nevi, which you have seen, more common in the chest region. Gynecomastia, jaundice, loss of the sexual hair, and there is a flapping tremor. Bleeding tendency, as mentioned earlier, maybe it is because of decreased prothrombin or an increased pressure or both. Secondary to it, there can be an anemia. Gonadal dysgenesis, atrophy will be there. And because of the hypoproteinemia, there will be an edema. So this particular one is of great importance. I think I am doing a service to the students of medicine. Please go through the sites of portosystemic anastomosis, what is ascites as such, what are the effects of portal hypertension, and what are the effects of liver failure. So this is it. In medicine, it can be a long case. In pathology also, it can be following a clinical history. It can be a long question, a short essay, MCQ, or viva voce. In any of this. This is one area, something like the bare area of the liver, which the students do not touch. That is why pertinently I had given this. Secondly, the cirrhosis I had included for the various classifications and the pathogenesis of cirrhosis. So cirrhosis can result in a liver failure and decreased in albumin, decreased in the oncotic pressure, leading to an ascites. Also, cirrhosis can result in portal hypertension, increase in the capillary pressure, and flow from the capillary bed is increased, again resulting in an ascites. Pressure overload as well as a volume overload. And this is as though a person has got a pot on his belly. You find that there is the umbilicus that is flattened. In fact, there are the various signs of the umbilicus itself in clinical medicine. A flushed one with the surface is indicative of an ascites. An indrawn umbilicus is a sign of obesity. And you find a protruding umbilicus is classical of an umbilical hernia. And what is this one? A puddle. A puddle is a small patch of water that is over here. And what is the puddle sign? You put the patient in a knee chest position and then do the percussion. You find that there will be a shifting dullness which can demonstrate about 50 to 100 ml of fluid, and that is called the puddle sign. Spasibo.